Hi, everyone. Welcome to our pre-recorded session for Rashes for the Team Physician. My name is Eliot Hu. I'll be your moderator today. We're very lucky to have Dr. Scott Paradise with us. He hails all the way from Guam. But before we get started, I'd like to establish some ground rules first. So this is the National Fellow Online Lecture Series. It's co-sponsored by the Education Committee and the Fellowship Committees, and it is an official subcommittee within the Education Committee. This is supposed to serve as an adjunct to your individual program's education and programming, and it provides the fellows and everybody else with direct access to educational experiences with AMSSM members and at times invited guest experts. And the main gist of this and the main purpose of this is to assist in CAQ exam preparation. So please mute your device's microphone and turn off your video. Because this is a pre-recorded session, we're not going to be able to answer your questions through the chat function. But there will be a Q&A session with some questions at the very end. If you have some urgent questions or things that you just want to ask, please enter them through the chat function, and hopefully the audience can answer them amongst yourselves as well. After the program, please complete the evaluation, which will be sent at the end of the lecture. So without further ado, I'd like to introduce Dr. Scott Paradise, who is a lieutenant in the United States Navy. He completed medical school at Penn State University prior to residency in family medicine at the National Capital Consortium in Washington, D.C. at Fort Belvoir. He subsequently completed fellowship in sports medicine at Camp Pendleton and now is serving as staff physician at Naval Hospital Guam in the South Pacific, where he does sports medicine in addition to inpatient medicine, outpatient medicine, and obstetrics. So Dr. Paradise, thank you for joining us today. I'm going to stop sharing my screen and please take it away.
All right, thank you so much. Let me pull up my PowerPoint here. Pardon me for the for technological understanding. Let's see, is it showing?
It is showing the PowerPoint. Oh, there it goes.
Okay, there you go. Yeah, so thanks so much, Eliot, for inviting me on to do this talk. I'm certainly very excited to be involved with this. I think this is a great program. I certainly watch a lot of these lectures myself out of fellowship and learn a lot each time. So I'm happy to share here. Hopefully we'll answer some questions that some of the fellows may see on their board exams, as well as just talk about some issues that may arise for physicians who are working with teams or with athletic departments, answer some questions that may arise during training room or consultations therein. So, I have just a couple brief disclosures. I am a military member. The views expressed in this PowerPoint are not necessarily those of the DoD or the Department of the Navy or the government. That said, we'll sort of go ahead and get started. So we're going to start just discussing some general infection prevention measures, as well as after we're done with that, move in through some specific rashes and reviewing. So how to diagnose, what is the recommended treatment, and what is most relevant to you guys is what criteria do we need to fulfill prior to getting our athletes back in competition. We'll also touch about MRSA very briefly as well. Okay, so why do we care about rashes? So they're pretty common. 1 out of 5 wrestling injuries that require medical attention are from skin infections. It can lead to significant time loss, not only days, but also weeks in a good amount of athletes. And they can also be bothersome. They occur on the head and face, and in some cases can lead to significant morbidity, which we'll talk about, particularly with HSV, can sometimes lead to vision loss and blindness. If they do occur, it's not only one athlete that can be affected. It can cause an outbreak, can lead to time lost for multiple members on a team, and rarely even multiple athletes in a season across multiple teams. So it deserves our attention. Athletes are particularly susceptible to rashes because of the close person-to-person contact. The stress from this causes breaks in skin barrier, which are entry points for infection. And they're also undergoing immense psychological stress from not only competition, but our collegiate athletes from scholarly stressors or the stressors of day-to-day life as an adolescent, which can lead to attenuated innate immunity, predisposing athletes to further infection risk. They are getting a little bit more media attention, and there is even the possibility of litigation with some of these rashes, particularly HSV. There's been students, particularly wrestlers, that have contracted HSV from wrestling, and that has ended in lawsuits. So something to know in and out how to take care of, recognize, and treat. So. So like any illness, if there's a way to prevent it, we should be focusing on that just as much as we are the treatment. So we'll talk a little bit about personal and institutional hygiene measures that we can leverage to prevent rash breakouts, as well as talking about education before getting into the actual treatment of rashes. Excuse me. So they're usually spread by direct transmission. We know this because rashes have a positional tendency among football and rugby teams. So if it was just sort of random and people picked it up from fomites or from locker rooms alone, then we would see, wide receivers would get rashes just as much as a lineman, and that doesn't quite seem to be the case. We also know this because of where our athletes get rashes, and wrestlers. 41% of rashes occur on the head and face, and on the particularly on the right side of the head and face, which is exposed in the lockup position seen on the bottom right here. And so there's a lot of evidence for direct transmission being the main culprit here. And because of that, we really want to harp on personal hygiene measures to prevent rashes. So showering immediately after competition, if you're unable to shower, baby wipes, and then we want to leverage hand washing too. We know from lots of studies, particularly in the hospital, and nosocomial infections, that hand washing, not only among athletes, but ATs and staff, can vastly help reduce infection risk. And then we also want to tell our athletes not to share equipment, not only wrestling or football equipment, pads, uniforms, but also towels, razors, bar soap, water bottles, stuff like that, which can be factors for infection. We want to ask our athletes not to shave if possible. The athletes with body shaving are about 6 times more likely to develop a MRSA infection. And there's lots of evidence that body shaving increases the risk for surgical infections as well. So if they can avoid shaving, that'd be ideal. We know that certain populations are just not going to listen to you, and they're going to shave, like swimmers are going to shave. And so if they are going to shave, making sure that they're using clean razors, that they're not sharing razors, and that, if they do get a cut or a wound, that they seek medical care or tell their coach or tell their athletic trainer, and they get it treated appropriately. This is just underscored one more time. MRSA outbreak on the Rams. They found that a very large percentage of the players and staff were colonized with MRSA. For comparison, in hospitalized patients, I think about 7% of hospitalized patients are colonized with MRSA. Maybe a little bit more. So 40 to 46, certainly a large percentage of colonization. But we also know that MRSA, when we look at locker rooms in college football teams, that it's present, very prevalent on fomites, lockers, weights, bottles, floors, benches, etc. And we find that if we implement institutional cleaning methods based on hospital cleaning methods, that we can actually eradicate MRSA from these locker rooms and hopefully decrease MRSA prevalence thereby. And so we both have the personal hygiene measure, but also the institutional hygiene measures, which we'll talk a little bit more as well. And so we want to, if you are the team physician for a team or an athletic department, you want to make sure you adopt an institutional infection control policy. This should have detailed cleaning schedules. It should be posted wherever there's stuff that needs to be cleaned, and locker rooms, world baths, in wrestling areas, and we want to make sure we provide sanitizer anywhere that people are going to be, going in and out of doorways, and also liquid soap for showers and next to sinks, so that all these measures are immediately available for athletes and staff as well. I've included here an example table of a cleaning schedule. This is from the National Athletic Trainers Association paper. They put out a position statement in 2010 that has a lot of very good information. And one of the things I particularly like about that is this table that sort of goes through a typical cleaning schedule for a Division I wrestling program. Notice that they have the area that's being cleaned, as well as what it's being cleaned with, when it's being cleaned, how many times a day. They have different schedules for on and off season. And then they also tabulate how many labor hours or person hours per day that the recommended cleaning requires. So you can talk to your leadership and say, I need this many man hours or person hours to clean, this wrestling program to prevent infections, to help with budgeting or resource management, stuff like that. And then we also want to just educate our players, our coaches, our staff on the importance of infection prevention and rapidly identifying rashes. Studies have shown that if you just educate athletes and coaches, that you probably reduce the risk of rash spread and rash occurrence. So not only do you want to harp on personal and institutional hygiene, but you just want to tell people about the risks. And usually wrestling teams are pretty well versed in the risks. It's very common to get some of these rashes on wrestling teams, but we do want to make sure we do a good job educating as well. And this goes even for non-infectious lesions. So in studies of football players with turf burns, they found that MRSA abscesses developed exclusively at the site of uncovered turf burns in one study. And then in football players, they're 7 times more likely to develop a skin infection if they had a turf burn. So even the non-infectious rashes should be, brought to the attention of athletic training staff or coaches or medical professional to appropriately treat and evaluate. So again, just harping on that prevention and education aspect. Okay. Medical examinations often required for wrestling, not required necessarily for other sports. Should be conducted by somebody knowledgeable about what they're looking for. Of course, there should be appropriate lighting and exposure, shorts, sports bras based on anatomy, and then anything that the examiner needs for evaluation of rashes, culture swabs, microscopes, if they're facile in their use, should be available as well. And then we want to have these occur systematically. So in medical school, on our dermatology elective, they gave us these 3 little stickers and they had us put it all over our bodies, so under our hair, back of our elbow. And we had to pair up and find all the stickers on our partner. And it's hard. You can easily miss a small rash. And in a group of people who may want to avoid you finding a rash because they don't want to be withheld from competition, it can take a little bit of effort sometimes to make sure that you're doing a full systematic evaluation and not missing anything. So make sure you go systematically and you're careful about seeing every rash or any spot where a rash could occur. Okay. So we're going to sort of transition to treatment and return to play now. Generally speaking, if you have an infectious rash or if you have something that you're not sure about, it could be an infectious rash, you want to immediately remove that athlete or that player from competition until you can actually further evaluate or appropriately treat the rash. Thankfully, the NCAA and NFHS do have guidance for these rashes. They vary slightly, but they have very similar themes across treatment for these rashes. So we'll go into that a little bit more right now. So we'll talk about sort of the big 3 here: herpes simplex, tinea, and bacterial infections. And then we'll sort of circle back to a few more less common rashes at the end of the talk as well. Alrighty. So the first one we'll talk about, herpes simplex. It's transmitted by skin-to-skin contact through breaks in the skin barrier. This is sort of back to that lockup maneuver that we talked about earlier. It's very commonly on the right side of the face, as you can see in these 2 wrestlers. very often misdiagnosed acne, cellulitis, whatever it may be. It's so important to recognize, particularly in your wrestlers, because, as it being on the face, if you have ocular involvement, that can lead to herpetic keratitis, which can lead to blindness. And so very important to not only recognize, but also get to ophthalmology if you're concerned that there could be ocular involvement. I think this past summer in the Tokyo Olympics, there's an image going or a short video going around on Twitter of a wrestler who had lost her contact during the wrestling match, and then like picked it up, spit on it, and then like put it back in her eye and clean it off. That's something we definitely want to avoid for our athletes. Make sure they don't do that. If they lose a contact, not pick it up and put it back in their eye. So this is just a reiteration of what we already said. 1 out of 2 rashes are on the right head and neck. And so anybody with a rash on their face, head and neck, you always want to think about herpes simplex, particularly an athlete, that is, just because it's so common, so prevalent there, and can possibly lead to morbidity. How do we diagnose rash? Well, it's really based on how the rash looks, the herpes simplex rash looks, and then the history of it. We would see children a lot with facial herpes simplex, and they would just be constantly going back to the emergency department when this recurrent rash on their face and getting treated with antibiotics. So again, just having that in the front of your diagnostic mind or the top of your differential for an athlete comes in with a facial rash. Make sure you don't miss it. If you're unsure, you can, sort of in their vesicles that you can unroof. You can unroof that vesicle, collect some of that fluid, and send that to PCR or viral culture. Zinc smear, as you sort of see on the background here, it lacks a little bit of sensitivity, but can also be used to identify herpes if you're unsure about the diagnosis. Serology is less helpful. 1 out of 3 adolescents are seroconverters for HSV1, and about 50% of U.S. all comers, adults included, are seropositive, and so positive antibody doesn't really help you. And then the other part of this is that seroconversion can take as long as a month. So a negative antibody test doesn't really help you either, and so not as much help for the acute diagnostic phase. There may be a role for prevention, which we'll talk about in a few slides, but at least for the acute diagnosis, serology is not very helpful. Okay, so HSV treatment largely divided into primary or secondary HSV. Primary being the first infection, obviously, and secondary being a recurrent infection. Primary infections are usually worse. They're more widespread. They have more systemic symptoms: fevers, chills, local lymphadenopathy, malaise, treated for a longer duration. So 7 days to 14 days until no new lesions and lesions have healed or crusted over until resolution. Secondary, usually 1 to 5 days, depending on the antiviral regimen. The treatment is always better started sooner. We know that. And there are topical antivirals, but they don't seem to work as well for herpes simplex virus infections. As far as the NCAA is concerned, they recommend treatment for 5 days or 120 hours of herpes simplex infection, and they require that you don't have any new blisters for the past 72 hours. So treatment for 5 days and no new blisters over the past 3 days. Lesions must have a firm adherent crust, and you cannot cover active infections, of course. And that's sort of a general principle. If a rash is infectious, it should not be covered to allow participation. You should withhold them until they're fully treated. For high schools, it's a little bit more complicated. With the recurrent HSV, it's very similar. 5 days of antivirals, no new lesions for the past 3 days. Lesions should have firm adherent crust. For primary, they recommend a 10-day course and 14 days if there are systemic symptoms. But the same sort of, no new lesions, no evidence of ongoing infectivity, and lesions should have that firm adherent crust. They also offer this caveat for wrestlers that aren't treated with antivirals, and they say that it's okay for them to return to play if the criteria 1 through 3 are satisfied. So no adjacent lymphadenopathy, no new lesions, and then that firm adherent crust again. The NFHS also recommends that any close contacts for the 3 days prior to infection, they should be separated from participation and not allowed to participate for 8 days, and then examined by knowledgeable staff or coach or health professional. And if no rashes appear, then they should be allowed to return to competition. This comes from a study from work done by Anderson in Minnesota, where they found that 90% of infected individuals show lesions within 8 days of exposure. Excuse me. This was then re-emphasized later on when they had a herpes gladiatorum outbreak in Minnesota, affecting multiple wrestling teams, excuse me, across a high school competition. And they suspended wrestling for 8 days, and then they had people see their medical provider prior to getting back into wrestling. And they found that helped successfully curtail that outbreak. They found that very rare. I think there was only 2 cases among the whole competition that had breakthrough skin infections after that 8-day waiting period. And they kind of suspected that was not due. That was due to poor quarantining, I guess, measures as opposed to a change in the natural history of infection. So. And then the other thing you want to think about is, if a wrestler does have an outbreak during the season, are they a candidate for season-long prophylaxis? The NFHS specifically recommends considering that in their position statement. So with regards to pharmacologic prophylaxis, there's some questions about that. Who gets it being the biggest one? Do we give it only those who have had herpes simplex in the past? All comers on a team, all staff, who only after an outbreak on the team, or should we, somehow incorporate serology into this discussion? And so first, one option, rely on history alone. That probably doesn't work. Only 3% of wrestlers at one wrestling camp reported a history of HSV. But again, we know that 1/3 of them will have HSV-1 antibodies. And so maybe just history alone may not be totally sufficient. And then we also know that waiting for an outbreak on a team might be too late, right? So even before the clinical syndrome of a rash appears, you can have asymptomatic viral shedding. We know this. If an outbreak does occur, it can spread rapidly and happen quickly. And before you know it, multiple wrestlers or multiple athletes among a group can be shut down because of this rash before you have a chance to react. So who gets prophylaxis? Wrestlers with a history of HSV, probably not a bad idea, particularly if they have a history of herpes simplex within a season. It might be a good idea to offer them prophylaxis antivirals for either the duration of the season, especially if that's recurrent, right? To get multiple outbreaks during a season is probably a good idea. If they have a history of HSV-1 antibodies and no history of clinical infection, possibly that sort of becomes less clear. And then there are wrestling camps that recommend universal prophylaxis, and then some wrestling teams as well, particularly collegiate teams. Questions you have to ask yourself is, are there a history of outbreaks on this team? What is the level of competition of the team? I think is a factor to consider. And then, are there immunosuppressed members of the team where, if they get HSV, could that become more of a big deal than somebody who has an immunocompetent or is a better functioning immune system? So once you decided who should get prophylaxis, well, what should you use for prophylaxis? And then these are a couple studied regimens. Acyclovir or valacyclovir, both are reasonable. The valacyclovir is probably the more common one, just ease of use. 1 gram daily for the duration of the season or the event. In a study at a wrestling camp over 10 years, they found that they both worked about the same. If the valacyclovir is probably a little bit better than the acyclovir. And the reason for that is probably just because people miss doses with the acyclovir. if you miss more than two doses or more a week, then you have a higher likelihood of getting the disease, and that's just much more likely with the BID dosing than the daily dosing. But works very well at preventing HSV outbreaks. So moving on to ringworm, Tinea gladiatorum or corporis. Tinea gladiatorum caused because it occurs in wrestlers, just like herpes gladiatorum. It sort of classically, this, we've all seen tinea, classically this circinate, centrifugally spreading, very itchy, very scaly rash. It can be sort of that classic appearance, but particularly in wrestlers, it can also be very subtle. And so I include this image on the right to see how subtle it can be. This is a wrestler with tinea right behind his right ear here. Wrestlers, or athletes may have that incentive, again, that we talked about earlier, to return to competition sooner than they otherwise would, or to avoid being withheld from competition. So they may alter the appearance of a rash, using mechanical means, abrading it or scrubbing it, or they may try over-the-counter topicals. They may not present immediately for evaluation. So topical steroids, topical antifungals, topical whatever, and try and alter that appearance, even using bleach at times to try and stay in the competition. So it can be subtle at times. This is Tinea gladiatorum, seen here on a KOH prep, the hyphae in the background, spread by direct contact. There are some studies that have been able to culture Tinea tonsurans, which is sort of the main Tinea species. They've been able to culture it from wrestling halls and wrestling mats, but it is a little bit more difficult. So we think it's primarily skin-to-skin contact. It typically incubates for a few weeks prior to from inoculation to clinical syndrome, and it's very common in tropical and moist environments. As opposed to herpes, which we treat with oral antivirals, we typically reserve topical treatments for tinea. So any number of azole, benzylamine, or allylamine can treat these and treat them well. You typically treat for a few weeks, treat until resolution, and then it's reasonable to continue for 1 week after resolution with treatment. And then if they do have resistant disease or potentially widespread disease and immunocompromise, you can always consider oral antifungals. With treatment failure, you always want to think of like reinfection or reservoirs for infection in the house. So if they have pets, particularly pets with rashes or hair loss, consider recommending take those to the vet and get them treated as indicated. Household family members, the tinea is very keratin avid, and so if wrestlers are very hairy, that might indicate that they may have a more resistant, or not resistant, but recalcitrant, difficult to treat infection. Certainly treating any comorbid onychomycosis or nail infection as well. This is very reasonable. The other thing you want to think about is incomplete treatment or non-adherence, or having is the diagnosis wrong? Is this something that was mistaken as tinea, but it's actually eczema? Is it HSV or something like that? Let's want to think of, do you have the right treatment? Resistance is very, very rare, particularly in immunocompetent individuals, but something to think about as well. I know some centers do resistance testing for certain point mutations in the tinea, and so if that's a concern, you can always submit scrapings or samples for testing at some institutions. To return to play, the NCAA and NFHS are very similar. Recommend 3 days of treatment. What differs in between those is the NCAA says that you can adequately cover lesions to allow participation prior to that 72 hours is up. That doesn't mean that they recommend covering infectious lesions. They still specify that lesion is non-infectious, and it should be covered by a gas impermeable dressing, pre-wrap, and stretch tape. NFHS says you can't cover prior to 72 hours, and you need that 3 days. Just a quick footnote here. Tinea capitis, separate clinical entity than Tinea corporis. which we treat with topical antifungals. Tinea capitis requires oral antifungals and requires at least 2 weeks of those prior to allowing someone to return to competition. Tinea capitis, again, head, much more common in pre-adolescence than tinea corporis. And so now we talk about treatment and recognition. Just like herpes, we can talk about pharmacologic prophylaxis. So particularly for wrestlers who have recurrent infections or maybe during an outbreak for the entire team, we have a couple evidence-based methods of prophylaxis here. One method is oral fluconazole weekly, 100 milligrams for the whole duration of the season. And another option proposed by Brickman in 2009 was you start 100 milligrams daily for 3 days prior to competition, and you repeat that regimen again at 6 weeks. In their study, they actually originally had the dose repeated at 8 weeks. But after the first year, they noticed a lot of breakthrough infections in those few weeks before that 8-week mark. And so after that first year, they switched their dosing from 3 days prior and then again at 6 weeks. And they noticed that they had a much better response rate in those few weeks that they were missing with the later dosing. So this decreased infections from 67% in their wrestling to 3.5% over the year. And that 3.5% does include that those initial breakthrough infections in that first year of the study. Neither study reported any severe adverse events, and then they also all breakthrough cases were successfully treated with oral fluconazole, the 100 milligrams in this case. So like anything, you have to balance the risks of medication with benefit to the athlete. Tinea, which could be considered more of a nuisance infection potentially than like a true morbid infection like HSV might be. The rationale for universal prophylaxis is not as strong, but certainly again if an athlete is prone to infection or if they have an outbreak on the team, it might be reasonable to consider. So now moving on to bacterial infections. Most infections among college wrestlers are bacterial as opposed to tinea or HSV. I think tinea and HSV account for 20% each, approximately, infections, and we have more than 30% from bacterial infections, predominance of which are impetigo, or superficial skin infection, typically caused by Staph aureus. And sometimes strep and sometimes some others, but very well treated with topicals because it's very superficial, as opposed to cellulitis, which is, or the skin and soft tissue beneath the skin, more often caused by root-based strep species than Staph aureus. Because of that, it's actually very well treated with beta-lactams. But like any infectious rash, you always want to consider the individual patient factors. Do they have risk factors for MRSA? Like drug use, known colonization, they have a history of penetrating trauma. The board question of the individual who is out, I don't know, reef walking or surfing, and they have a cut in their foot and then they develop infection later. Maybe you want to think of gram negatives or something else. So most often beta-lactam is sufficient, but again, think about the individual patient factors when deciding your antibiotic regimen. And then most importantly, beware of local resistance patterns. So a strep that I see here on Guam may be different from the strep that you see wherever you are. But yeah. With purulent infections, this is again like an abscess or carbuncle or furuncle. You want to always get that culture sample to guide management. What bacterial strain are we dealing with? What resistance are we dealing with? What susceptibility? This is particularly important if you're thinking about giving antibiotics or if you have an athlete or something that may require treatment. We know we have a rising prevalence of MRSA, and if we miss an infection, or if that infection later becomes a more serious systemic infection or deep lying infection, then we have that initial data from the initial culture to help guide us right away. You can, with an abscess, with an infected fluid collection, you can. The treatment is really surgical drainage, so incision and drainage. you can give adjunctive antibiotics. One study in New England Journal from a few years ago did show higher cure rates for when they combined trimsulfa with IND as opposed to IND in a placebo. But that improvement was somewhat small. The addition of trimsulfa did not improve the occurrence of severe deep infections like a sepsis or something, which was similar among groups. More often MRSA than not, well, I guess very, very commonly can MRSA present as an abscess. And so you always, if you are giving antibiotics, you do want to cover for MRSA. And again, if you are thinking of adjunctive antibiotics, you want to think of, what are the risk factors here? Do they have immunocompromise? Is there a history of MRSA? Is there, what are the local return to play requirements? And then what's the risk, right? So are you putting somebody at risk of developing a resistant strain? Are they side effect intolerant? What's their risk tolerance for something like a C. diff infection, which you want to think about as well. Just a little bit about MRSA. Community-acquired MRSA, typically a little less virulent than hospital-acquired MRSA and less multi-drug resistance, but it can still be more morbid. It's sort of known for that, being more morbid than your typical Staph aureus or your MSSA. One study, we talked about MRSA infections in professional footballers. One study from Pennsylvania wrestlers on the same team, 10 on the same team contracted MRSA skin infections in one season, and 7 of those required hospitalization. So it can still be virulent. Interestingly, we do see high, for whatever reason, high percentages of college athlete colonization with MRSA. So 13% of college athletes are colonized and 22% of college wrestlers. Again, this compares to about 7% of just your hospitalized patients in the US. And I think that's about on par with healthcare workers as well. So very, very high colonization rates of our college athletes. Okay. So typically, an abscess may be described as like a spider bite. Spiders always get blamed for the abscess. These poor guys. They're purulent. Again, we talked about culturing them whenever possible and getting enough culture material, more the better for the lab. So a tiny little swab is not going to be as good as a whole bunch of purulent material for that lab to run their testing on. Unlike pneumonia, for which nasal colonization, negative nasal colonization is a high negative predictive value for MRSA pneumonia. It's not as helpful for a skin and soft tissue infection. So it gives us a little bit of idea of prevalence in the community, but for diagnosing, the etiologic bacteria in an abscess, nasal colonization does not help us very much. And again, we talk about risk factors, penetrating trauma, shaving, close contacts, history of MRSA infections as well. We've talked about prevention in the past. So what about decolonizing those athletes who have MRSA in their nares? Does that help? There's some studies about this. There's more studies in hospitalized patients and in pre-op patients in decreasing MRSA skin and soft tissue infections. There are a few studies in athletes as well, and they do show decolonization with specifically with nasal mupirocin or oral rifampin does decrease the rate of MRSA skin and soft tissue infections. But the possibility of causing resistant strain or contributing to resistance in the community is much more likely with that bacterial infection. So it's controversial. It's not something that I would probably recommend routinely. If you do have an outbreak, it may be worth reaching out to an infectious disease colleague and talking over the case and considering it then, but sort of still controversial at this time. With regards to return to play, it's kind of similar for all bacterial infections. The NCAA and the NFHS recommend 3 days of oral antibiotics. No active moist drain lesions, so non-infectious, no new skin lesions for the past 2 days for the NCAA. Generally speaking, again, you should not be covering infectious rashes or infectious lesions to allow someone to participate in wrestling or whatever sporting activity. You should make sure they're non-infectious prior to return to play. And these recommendations are similar whether or not it's an abscess or cellulitis or an topical as well. A quick comment on hidradenitis suppurativa. You may want to think about if an athlete comes in with recurrent abscesses, particularly in intertriginous areas, groin, axilla, under their breasts. This affects the apocrine glands, which are highly prevalent in those areas, and you can have just chronic inflammatory lesion recurrence. Even though these are not typically infectious, the NCAA still does require disqualification if they have a draining lesion, unfortunately. So something to think about with the athlete that keeps coming in with abscesses. Okay, so we've kind of talked about the big three, the herpes, the tinea, and the bacterial infections. Now we'll sort of finish with kind of a rapid review of various rashes before kind of calling it quits. Start scabies, that rash that makes everyone instantly itchy thinking about. We sort of see those, classic burrows and those very itchy pruritic excoriations next to them. Treated with, a topical permethrin or ivermectin. The NCAA says that to return to play, they must have a negative scabies preparation. I don't really specify what that is, but that can probably be interpreted as no mites or debris under microscopy. Recall that if you treat scabies, you can have the itching and the inflammatory syndrome is really caused by the debris in the scabum, which can linger even beyond eradication. So sometimes that clinical syndrome of itching, which can last for 1 or 2 weeks after a treatment, may not be the best indicator of are they ready to return to play. The NFHS doesn't really provide any guidance. And there's a lovely little picture of a scabies mite to hunt your dreams. Okay, lice. Lice, must be treated with the appropriate pediculicide. And per the NCAA, re-examine for complete response. So we call it when if you have a kid and you're looking for lice in their hair, they're sent to you from school or something, it's not sufficient to see nits to diagnose an active infection, right? Because nits, can be debris or empty shell casings. You actually need those live lymphs, live lice, nymphs or adults to be able to diagnose active infection or treatment failure. And so yeah, I would say that if you do have the nits, as long as you don't have the lice, that you can still say that's not necessarily an active infection. Again, the NFHS doesn't provide any specific guidance on this. Warts, not as infectious as some of our other rashes we've talked about today. NCAA says that they can generally be covered if you have like a filiform wart or a digitate wart on the face that can't be covered with a mask, you can curette it. But if you do curette a wart or any lesion, really, it can't be like seeping. It can't be discharging any material that could be potentially increasing its infectivity. Again, adequate covered per the NCAA is a gas impermeable dressing, pre-wrap, and stretch tape that's well anchored, can't be dislodged during sport. NFHS says just cover it if it's prone to bleeding. On the left, we have verruca vulgaris and verruca plana. Just cover those, particularly if they're prone to bleeding for high schoolers. On the right, we have 2 facial filiform warts, and those sometimes can represent difficulty with covering, and so you can curette those or have those removed. All right. Molluscum, very, very contagious. Commonly happens in children more than adults or teens. If it does happen later in life, or particularly if it's widespread, you may want to consider like an immunocompromise or condition. These, the NCAA says if they're localized, you just cover them. Otherwise, you have to curette them or remove them. The NFHS says they're not allowed to play. They offer the option of expressing material from each vesicle, hybricating, and covering with a bio-occlusive dressing. That's that. So just to sort of wrap up here, I'm presenting this table here. This is a table that Dr. Hu and I worked on in our paper that was published last year in CSMR, Current Sports Med Reports. We kind of wanted to create sort of a one-stop shop for any questions about rashes that may pop up during your clinical practice or during your, the training room. And I think we did a good job of that. Sort of goes through all the rashes and treatment recommendations. And then I think this table in particular, I think it's like table 2 or something, will really help out with some of those decisions. Certainly nicely summarizes the recommendations for return to play for high school and for NCAA. There are also some other resources that I recommend. There's the NCAA Sports Medicine Handbook, as well as their Wrestling Rules Book, which is updated every 1 to 2 years. And the NFHS publishes a position statement and guidelines as well regularly, most recently in 2018. Again, we mentioned earlier in the talk, the National Athletic Trainers Association has an excellent position statement that has anything you might want to know about skin diseases. That was from 2010. And then again, a little plug for our paper that we wrote last year as well. So here's just some references that I have on some of the stuff we talked about today. And then if you have any questions, feel free to comment on the YouTube video and maybe answer them in the community, or you can reach out to me on Twitter as well. It's just a picture of Tumon Bay in lovely tropical Guam, where I am right now. All right, so with that, I'm gonna stop sharing my screen and send it on back to Dr. Hu.
Thanks, Dr. Paradise, for giving that excellent talk. It was definitely a great summary of everything. And I would encourage everybody to take a look at that table. That's the NAT guidelines. I have it saved on my phone. So when I was taking care of college athletes and professional athletes, I always would pull it up, reference it, just to make sure that I'm not missing anything or anything like that. Without further ado, we'll get to some questions as well. First question for you, Dr. Paradise. Comparing personal versus institutional cleaning, what do you think is more important for, well, which one do you think is actually more important for infection prevention?
Yeah, it's a tough question. It's kind of like having to choose between, which is your favorite child a little bit. They're both important. Especially infections like TINEA, where we think it's predominantly spread person to person. Personal hygiene is so paramount, making sure they're, taking care of any open lesions, making sure they're cleaning before and after wrestling matches, stuff like that. But we have lots of evidence from MRSA in particular that these can be transmitted by fomites or on surfaces. We have evidence from not only athletic studies in athletic populations, but tons of evidence from hospital studies that say institutional cleaning recommendations work and they reduce infections. And so it's kind of both. You can't have one without the other, in my opinion. You kind of need to harp on both the personal and the institutional.
Yeah, that tends to be what I believe too. But after experiencing professional sports and collegiate sports as well, you understand that some people, they either don't have the time or they just don't care. And so we try to do the best as we can on our side, but we still have to give them some responsibility too. Yes. Second question, for institutional cleaning schedules, at least according to the NATA sample that you put up as well, does this apply to swimming pools and ice baths? And if so, how often should these be cleaned? Because I didn't see anything in there.
For sure. So yeah, so it should. Ice baths, whirlpools, hydrotherapy tubs, those should ideally be cleaned after every use. So drained, cleaned. Usually the manufacturer has like a specific disinfectant or disinfectant type that they recommend. But any EPA certified or registered disinfectant should work for that. But that should be after every use. I think pools is a little bit different. I think that's actually state regulated, if I'm not mistaken. But it's usually done with chlorine. So there are like specific parts per million concentrations of chlorine that's supposed to be monitored, once or twice a day. pH that's supposed to be monitored. And there's specific recommendations, like if you have like an infection event or a soiling event or something like that, how to respond to that. I know the CDC does publish guidance on that though. So if you're on a group that's involved in deciding, cleaning schedules or cleaning methods or, monitoring for a pool for like a swim team or something, you can always leverage the sort of CDC published recommendations.
Yeah, I think that's important to note because, oftentimes people assume that, oh yeah, because there's chlorine in the swimming pools, it's not supposed to be infectious or it helps actually clear out infections, but that's actually not true. So it has to get tested first. And then based on those testing, then you have cleaning guidelines and chemicals and all that. So, all right. Lastly, not necessarily specifically pertaining to herpes simplex, but for herpes simplex, for TINEA, you did list some chemo or medication prophylaxis during the season. Do you actually worry about development of drug resistance in these cases?
Yeah, so it's always a worry when you are targeting biologic agents. Are they going to develop resistance to the medicine that you're using? So so with HSV resistance. So the acyclovir and the valacyclovir, which is a prodrug of acyclovir, they are activated by the viral thymidine kinase, which phosphorylates that medicine and allows it to eventually work its action on DNA polymerase. That process is the main process that by which resistance develops. So they're deficient or they have absent thymidine kinase. That is very, very rare in the general immunocompetent population. It's like less than 1%. In immunocompromised persons, that's a little bit more common. I think I've seen up to 5% or so. But thankfully, that thymidine kinase deficient variant is also less pathogenic. It's less virulent. So in the case of HSV specifically, I don't worry too much about developing antibiotic or antiviral resistance. And then I mentioned acyclovir. The famciclovir undergoes the same process, being converted into penciclovir as valacyclovir to acyclovir, and it undergoes the same process by phosphorylation by thymidine kinase. So I don't worry too much about antiviral resistance. If it does occur, it's an immunosuppressed individual, and it typically occurs with a less virulent strain, which will go away or self-resolve typically on its own. I mentioned this briefly about the TINEA. There are certain mutations that TINEA can develop and cause resistance to the antifungals. It's typically less common again, but it's becoming a little bit more common. That's why if you have like a resistant case, you can consider submitting scrapings to like a local lab or something if they do susceptibility testing. But it may be worth thinking about, those other reasons for infection resistance. So are there reservoirs that you're missing? Is there close contacts that are reinfecting this member? Is that TINEA just living in the hair follicles and you need a more robust treatment course or a deeper treatment course with orals or something like that? That's what I probably think about before resistance in those cases.
Yeah, makes sense. I always think back to when I covered high school wrestling and collegiate wrestling as well. Most of those kids, they've already come through with history of HSV anyways. And then the athletic trainer is asking me, hey, can you just give them all prophylaxis? And I'm like, I'm writing a prescription for the entire team, and now for the next 4 years. So, come on. And so, it's something that's always on my mind. But I did it anyways because, it's better than managing an outbreak. But I often wonder about, how much of this in the next, let's say, 10 years, we're going to start seeing some really drug resistant, bacteria or fungus or viruses. So, well, that concludes our talk today. Thank you, Dr. Paradise, for joining us all the way from Guam. It's a pleasure to have you, as always. And please fill out the evaluation form, and we will see you next time.
Thanks so much.